This is a nutrition review for general medicine, the gastroenterology unit in spring quarter. Today we're going to cover a couple of topics about nutrition therapy, vitamin mineral absorption sites, celiac disease, being gluten-free, bariatric surgery, the pre and post-surgery diet, and irritable bowel syndrome and irritable bowel disease. Objectives for this lecture include identify the locations of macro and micronutrient absorption in the GI tract, correlate the gastroenterological pathologies discussed in lecture with how their pathophysiology affects nutrient absorption, state the treatment for celiac disease and identify sources of gluten. Recognize the specific nutrient deficiencies and understand how they relate to the GI pathologies discussed. Celiac disease, bariatric diet, irritable bowel syndrome, and irritable bowel disease. Next, describe the specific nutrient goals of a pre-surgery bariatric diet. Objectives continued. Discuss the importance of protein intake at different stages in the post-bariatric surgery patient. Recognize the various treatment modalities to help improve irritable bowel syndrome symptoms. Differentiate the general dietary strategies for the irritable bowel syndrome patient. Explain why patients with irritable bowel disease are prone to becoming malnourished. Recognize the 4 consequences of malnutrition associated with irritable bowel disease. Discuss the importance of restoring and maintaining good nutrition in the management of irritable bowel disease. For the topic of nutrient absorption, we will talk about the macro and micronutrient absorption sites. Macronutrients are carbohydrate, protein, and fat, and micronutrients are vitamins and minerals. We'll start out by discussing nutrient absorption overall, and then we will go through the specific macro and micronutrient absorption sites. So most nutrients are large molecules that must be broken down into smaller molecules that can be absorbed. Digestion is the chemical breakdown of food by enzymes and can occur at all 3 of the following sites: luminal digestion, membrane digestion, and intracellular digestion. Luminal digestion occurs within the lumen of the gastrointestinal tract and is mediated by enzymes from the salivary glands, the stomach, and the pancreas. Membrane digestion is the action of enzymes fixed to the brush border membrane of enterocytes. Such enzymes are synthesized by enterocytes and inserted into the membrane. And finally, intracellular digestion is mediated by cytoplasmic enzymes within enterocytes. So nutrient absorption occurs in the small intestine. The proximal small intestine absorbs most of all of the iron and calcium that is assimilated from food. Carbohydrates can be absorbed along all parts of the small intestine, but their absorption is usually completed in the proximal small intestine. Absorption of other nutrients, including protein, fat, salts, and water, is spread more uniformly along the small intestine, while bile acids and vitamin B12 are absorbed specifically in the distal ileum. Carbohydrate digestion. Carbohydrates are the major source of calories in the Western diet, with about 400 grams per day consumed. This is made up of approximately 60% starch, 30% sucrose, and 10% lactose. Digestion reduces carbohydrates to their component monosaccharides, glucose, galactose, and fructose. There are specific enzymes that break down the carbohydrates and the final products of digestion. A clinical pearl is that lactase deficiency is common in adults from non-white populations and results in milk intolerance, with manifestations of osmotic diarrhea and bloating due to fermentation of lactose in the colon. Next, we'll move on to protein digestion. Dietary protein is assimilated either as amino acids or small peptides. A combination of luminal digestion, membrane digestion, and intracellular digestion is used to break down proteins. Luminal digestion begins with pepsin in the stomach. The partially digested proteins that enter the small intestine are hydrolyzed by 3 pancreatic endopeptidases, and they are acting on internal peptide bonds. These are called elastase, chymotrypsin, and trypsin. Fat digestion includes triglycerides, which are the most abundant dietary form of lipid. Other lipids include phospholipids, sphingolipids, sterols, and the fat-soluble vitamins A, D, E, and K. Non-dietary sources of fats include lecithins and cholesterol from bile, sloth enterocytes, and microbes. Lipid digestion involves a mechanical phase and a chemical phase. The mechanical phase includes chewing and grinding peristalsis in the stomach, which together create an emulsion with large fat droplets being sheared into smaller droplets. When chyme enters the small intestine, bile is added. Bile salts reduce surface tension at the fat droplet and water interface, and further aid in the formation of a fine emulsion. The chemical phase of fat digestion occurs when lipases remove fatty acids from the triglyceride molecules. Lipases are termed as acid or alkaline lipases based on their pH optimum. Lingual lipase from the salivary glands and gastric lipase from the fundus of the stomach are acid lipases, with a pH optimum between 3.5 and 5.5. A clinical pearl is because the pancreas normally oversecretes lipase, ingested fats can be hydrolyzed with only 10% of the lipase secreted. A patient with chronic pancreatic insufficiency is likely to have experienced very extensive destruction of the gland by the time the clinical signs of maldigestion become apparent. Examples: steatorrhea, bloating, colonic distension, gas, and nutrient excretion in feces. Moving on to vitamin absorption. Vitamins are organic molecules that are required for metabolism but cannot be synthesized in the body. Therefore, vitamins must be present in the diet. Vitamins A, D, E, and K are fat-soluble. A meal must contain fat if these vitamins are to be assimilated from food. Fat malabsorption is associated with a deficiency of fat-soluble vitamins because the vitamins are excreted along with excess fecal fat. The water-soluble group of vitamins includes the B vitamins, vitamin C, folate, biotin, and pantothenic acid. Intestinal absorption of these water-soluble molecules by simple diffusion is slow. Although not yet fully understood, separate carrier-mediated transport mechanisms have recently been identified for each of the water-soluble vitamins. Vitamin B12 uptake. Vitamin B12 deficiency may take months to manifest clinically because the liver stores a significant amount of the vitamin. Untreated vitamin B12 deficiency results in anemia. A pearl is the mechanism for assimilation of vitamin B12 requires normal function in several gastrointestinal organs. As a result, there are multiple etiologies that lead to vitamin B12 deficiency, including dietary deficiency, lack of intrinsic factor known as pernicious anemia, which may be caused, for example, by autoimmune destruction of the parietal cells or by gastric atrophy, pancreatic insufficiency, example cystic fibrosis, surgical resection of the ileum, terminal ileum disease or Crohn's ileitis. The ileum is the most common location of Crohn's disease. Intestinal organisms, such as a fish tapeworm. Another pearl is, regardless of its cause, vitamin B12 deficiency manifests as a megaloblastic anemia, a neurologic degeneration caused by demyelination of the peripheral nerves, spinal cord, and the cerebrum. Treatment of vitamin B12 deficiency with only supplemental folic acid should never be attempted. The folic acid will resolve the anemia, but without B12 replacement. The patient will have irreversible neurologic dysfunction. So nutrient absorption should be completed by the time the luminal contents reach the large intestine. The main function of the large intestine are completion of fluid absorption and the storage and elimination of fecal waste. Most water absorption occurs in the right colon, the cecum, the ascending colon, and the first half of the transverse colon. Prior to defecation, fecal waste is stored in the left colon, the distal half of the transverse colon, the descending colon, and the sigmoid colon. By the time fecal material reaches the rectum, it consists of a small volume of potassium-rich fluid containing undigested plant fibers, bacteria, and inorganic material. Speaking of dietary fiber, the main undigested material in feces is non-starch polysaccharides, including cellulose, hemicellulose, lignin, pectin, gums, and algyl polysaccharides, which are collectively called dietary fiber. A high-fiber diet improves colonic motility and reduces the incidence of constipation. Health benefits in other body systems are also associated with high-fiber diets, including reduced incidence of coronary heart disease and improved control of blood glucose concentration in type 2 diabetes, also called non-insulin dependent diabetes mellitus. Dietary fiber undergoes fermentation by bacteria in the colon, which produces the short-chain fatty acids acetate, propionate, and butyrate. Short-chain fatty acids create a more acidic colonic fluid, which prevents bacterial overgrowth. Fermentation reactions also produce gases. Example, hydrogen, methane, carbon dioxide, and hydrogen sulfide, which are excreted as flatus. Moving on to our next topic of celiac disease. Celiac disease is an autoimmune disorder that affects the small intestine. 1 in 141 people are diagnosed in the U.S. each year. Ingesting gluten causes damage to the lining of the small intestine, and this prevents nutrient absorption. In this picture here, you can see the lining of the intestine, and the healthy villi are standing up tall, ready to absorb nutrients, while the villi affected by celiac disease are lying flat. Symptoms of celiac disease include abdominal pain, bloating, gas or indigestion, constipation, decreased appetite, diarrhea, and lactose intolerance. Diagnosis includes history and physical exam, blood tests for antibodies, and biopsy tests of the small intestine. Patients can have either gluten sensitivity or intolerance or gluten disease. The treatment for gluten sensitivity or gluten intolerance and gluten disease is a gluten-free diet. After starting the gluten-free diet, symptoms can be resolved in up to 97 to 100% of patients. If symptoms are not resolved, consider some differentials, such as small intestine bacterial overgrowth, also called SIBO, malabsorption of lactose or fructose, parasite infection, irritable bowel syndrome, or inflammation of the colon. After starting a gluten-free diet, diarrhea often improves within about 4 weeks, and constipation improves within 6 months. Nutrition deficiencies with celiac disease can lead to osteoporosis and iron deficiency anemia. Gluten is a protein. It's found in grains like wheat, barley, and rye. There are grains that are gluten-free, and here are some examples, one being almond flour, another being potato starch, and another being quinoa. Here is a list of other grains and flours that are gluten-free. And notice here uncontaminated oats. So that means oats that were not contaminated with wheat during processing. And these are labeled as gluten-free oats. Foods that are naturally gluten-free can include vegetables, nuts and seeds, some grains that we had talked about previously, legumes, fruits, and foods that include healthy fats like olives and avocados. Here is a list of other naturally gluten-free foods. You might look down at the last item here, water distilled alcoholic beverages such as vodka and gin, and vinegars except for malt vinegars, wines, and gluten-free beers. There are certain foods to avoid because they may contain gluten. Some of these are wheat and different types of wheat, rye, barley, and triticale, malt products, and other foods including alcohols, and oats not specifically labeled as gluten-free. Avoid processed foods because gluten is often added to processed foods to add taste and texture. It is also added to non-food items like medications, vitamins, lotions, and even Play-Doh. When consuming a gluten-free diet, it is important to avoid processed foods. Here is a list of processed foods that may contain gluten. Some examples from this list are bouillon cubes, cold cuts, french fries, rice mixes, salad dressings, stuffing, soups, soy sauce, thickeners, and vegetables in sauce. In 2014, the Food and Drug Administration administered guidelines that manufacturers must follow for labeling foods as gluten-free. More specifically, the final rule defines gluten-free as meaning that the food either is inherently gluten-free or does not contain an ingredient that is derived from a gluten-containing food. Also, any unavoidable presence of the gluten in the food must be less than 20 parts per million. This final rule applies to all FDA-regulated packaged foods, including dietary supplements. The rule excludes those foods whose labeling is regulated by the U.S. Department of Agriculture and the Alcohol and Tobacco Tax and Trade Bureau. There are also independent gluten-free certifiers. For example, the Celiac Support Organization tests products to less than 5 parts per million of gluten. Something to be aware of for celiac disease patients is cross-contamination and cross-contact with gluten. They are two different things. Cross-contamination is when harmful bacteria are transferred to a food from another food or surface. Most dangerous bacteria can be killed through proper cooking. Cross-contact is when the food allergen or gluten is transferred to a food meant to be an allergen or gluten-free. A key difference here is that offending food proteins remain dangerous after cooking. Medications may contain gluten. Labeling gluten-containing ingredients in medication isn't legally required, and it's often the inactive ingredients, binders, or fillers that can be potential sources of gluten. Pay attention to the inactive ingredients, particularly anything with starch or dextrin, unless it states a gluten-free grain as the source. Here are some more resources from the American Dietetic Association's website, www.eatright.org. Next, we're going to talk about bariatric surgery and the pre and post diet. Pre-bariatric surgery diets typically begin 2 to 3 months before gastric bypass surgery. Depending on a person's health, weight, and body composition, bariatric surgery candidates are generally put on a diet by their surgeon or dietitian ranging from 800 to 1200 calories per day and consisting of 70 to 120 grams of protein per day. This diet also typically calls for a much lower intake of carbohydrates and dietary fat, especially refined sugars and saturated fat. A 1,000 calorie diet per day is a tough diet to stick to. It really isn't very much food. But depending on your food choices, it can look and feel pretty different. I found these two pictures to help describe this. The picture on your left is a 1,200 calorie diet menu, and as you can see there are 4 meals here, each containing about half a plate of vegetables. On the right here is a happy and healthy Thanksgiving plate. It's 1,000 calories in one plate. So you can see here how it's easy for calories just to add up and to only be one meal versus spreading the calories out throughout the day. I have another picture here showing you what 200 calories looks like. As you can see, the volume of 200 calories in different foods is very different. 200 calories of celery will give you a lot more than 200 calories of small pieces of candy. A pre-surgery bariatric diet is designed to reduce body fat, preserve lean body mass, prepare the body for post-surgery recovery, and prepare the patient for the post-surgery diet. In the next slide, I will expand on these ideas. And more specifically, to reduce body fat, especially the deposits of fat around the abdomen in the midsection, since this is the specific surgical area. This is beneficial to the safety of the patient. Preserving lean body mass. Intake of sufficient amounts of protein is anti-catabolic or protein sparing. This means that getting adequate protein prevents the body from utilizing lean muscle tissue as an extra energy source while losing body fat on a calorie-restricted diet. To prepare the body for post-surgery recovery, eating healthy, increasing protein intake, and avoiding refined carbohydrates, sugars, and saturated fats provides the body with beneficial nutrients, vitamins, and minerals that will help prepare it for the nutritionally demanding post-bariatric surgery recovery. Prepare the patient for the post-surgery diet. Following a reduced calorie, higher protein, low carbohydrate diet is essentially the way a bariatric surgery patient will be eating for the rest of their life. Therefore, before surgery, it's the best time to get used to making healthy food choices and using protein diet supplements that will be needed after surgery. General guidelines for pre-surgery diet include Eat balanced meals with small portions. Follow a diet low in calories, fats, and sweets. Keep a daily record of food portions and of calorie and protein intake. Eat slowly and chew small bites of food thoroughly. Next, we're going to talk about the post-op bariatric surgery dietary guidelines. First is a liquid diet. Second is pureed foods. Third is soft foods. And fourth is solid foods. It's important to know that following surgery, the stomach size is very small, less than 1/4 a cup, or about the size of an egg. The opening that allows food to pass out of the stomach is also very narrow. And I have a picture here that shows before gastric bypass surgery what the stomach looks like, and after gastric bypass surgery. And you can see here in green, the stomach gastric pouch is very small, about the size of an egg. So right after surgery, the stomach is very small, so it's important to take only 2 to 3 sips or bites at a time of any new food, and then wait 10 minutes before taking more. This will help the patient learn their limits and tolerance. Liquids will empty faster from the stomach than soft solids. If the patient overeats or eats too quickly, that can cause nausea or pain. Avoid rich, creamy liquids such as gravies, sauces, and ice creams. The first 2 weeks after surgery is a liquid diet. That includes juices, jello, and broth. Over the next 2 weeks, add thicker liquids. The goal is to consume small portions that will empty easily from the pouch. Begin with 1 tablespoon portion sizes and increase to 2 tablespoons as tolerated. Begin drinking 1/4 a cup of liquid at a time and increase to 1/2 cup as tolerated. Daily caloric intake should not exceed 400 calories. Stay hydrated and drink 1 to 1.5 liters of water or other non-caloric liquids per day. Recommended thicker liquids might include milk, if they can tolerate milk, or lactose-free drinks, sugar-free pudding, non-fat yogurt that's also sugar-free, low-fat cottage cheese, refined hot cereals that are low in fiber, and high-protein, low-calorie liquid supplement drinks. For the diet that is 2 to 4 weeks post-surgery, the patient will begin adding very small portions of pureed and soft foods as tolerated. Take very small bites and chew everything very well. Do not take more than 2 bites every 20 minutes when adding a new food. The diet for 2 to 4 weeks post-surgery can include these recommended pureed and soft foods: applesauce, yogurt, cottage cheese, well-cooked pureed vegetables, hot cereals, mashed potatoes, noodles, scrambled egg whites or egg substitute, canned fruits, canned tuna fish, lean fish, tofu, lean ground meats or poultry, and avoid all bread and meats that are not easily chewed. Patients should remember to drink 1 cup of water or other non-caloric fluids between meals. It is important to take a multivitamin and mineral supplement every day, plus additional iron if required, and calcium and vitamin D supplements 2 to 3 times per day. We will talk more specifically about supplements in a bit. About the time I was asked to give this lecture, I reached out to a bariatric dietitian friend of mine. I asked her, what are the most important parts of a bariatric surgery diet? And she reported, it's very important to follow the diet, put protein first, take prescribed vitamins religiously, keep liquids separate from meals, and a big piece is the emotional eating. Get it under control prior to surgery, because otherwise the pouch will stretch back to normal and weight gain will occur. The recommended meal plan for 2 to 6 months post-surgery includes consuming 900 to 1,000 calories and at least 65 to 75 grams of protein, and discontinuing drinking that high-protein liquid supplement, drinks or powders that the patient might have, if possible. It's recommended to meet protein needs with food. Recommended meal plan for 2 to 6 months post-surgery. The recommendation is for balanced nutrient intake. Daily servings should include 3 servings of milk and dairy products, 3 servings of meat or meat alternative, 3 servings of starch, limit bread and rice, 1 serving of fruit, avoid dry fruits and fruits with skin, 2 servings vegetables, well cooked only. Recommended portion sizes are 1/4 a cup for solids and 1/2 a cup for liquids. Recommended meal plan for 6 months post-surgery and beyond. Continue consuming 900 to 1,000 calories per day. Decrease to 3 meals and only 1 to 2 snacks per day. Discontinue taking high-protein liquid supplement drinks. Increase the variety of low-fat, low-sugar, and low-calorie foods as tolerated. And avoid raw vegetables, fresh fruits with skins, dried fruits, breads, popcorn, nuts, and red meats only if poorly tolerated. A note on fluids. Drink extra water and low-calorie or calorie-free fluids between meals to avoid dehydration. All liquids should be caffeine-free. Sip about 1 cup of fluid between each small meal 6 to 8 times a day. It is recommended to drink at least 2 liters of fluids a day. Patients are strongly warned against drinking any alcoholic beverages. After surgery, alcohol is absorbed much more quickly than before, making its sedative and mood-altering effects more difficult to predict and control. A big key about the diet is to eat protein first. Preserve muscle tissue by eating foods rich in protein. High-protein foods include eggs, meats, fish, seafood, tuna, poultry, soy milk, tofu, cottage cheese, yogurt, and other milk products. The goal should be a minimum of 65 to 75 grams of protein a day. Here is a picture to show you about how much that is. So each of these similar foods contains 30 grams of protein. So for example, 5 eggs is 30 grams of protein. So the patient trying to get 65 to 75 grams of protein is really having to eat a lot of protein. Supplements are taken on a daily basis to prevent nutrient deficiencies. All pills must be crushed or cut into 6 to 8 small pieces, and whole pills cannot be absorbed, and it can be difficult for the pills to pass through the new anatomy. Multivitamins. Take a high-potency daily chewable multivitamin and mineral supplement that contains a minimum of 18 milligrams of iron, 400 micrograms of folic acid, selenium, copper, and zinc. Take 2 tablets daily for 3 months, and then 1 tablet daily for life. Calcium supplements. Take 1,200 to 2,000 milligrams of calcium daily to prevent calcium deficiency and bone disease. To enhance absorption, take the calcium in 2 to 3 divided doses throughout the day. Calcium citrate is the preferred form of calcium. Above is a picture of 2 calcium pills. Each pill is 600 milligrams of calcium citrate. Vitamin D supplements. Take a total of 800 to 1,000 international units of vitamin D each day. This total amount should be taken in divided doses of 400 to 500 IUs twice a day. Vitamin D should be taken with the calcium supplement. A combination of calcium, vitamin D supplement could also be taken to avoid taking multiple pills, so long as it contains the proper doses. Vitamin B12 supplement. Take 500 micrograms of vitamin B daily. It can be taken as a tablet or in sublingual forms placed under the tongue. Other supplements. Some patients might need additional folic acid or iron supplements, particularly women who are still menstruating. Post-surgery, the goal is limiting the amount of calories you consume while providing balanced meals that help prevent nutrient deficiencies and preserve muscle tissue. Next, we're going to talk about irritable bowel syndrome. Irritable bowel syndrome is a group of symptoms that affect the large intestine. Symptoms include abdominal pain, cramping, constipation or diarrhea, bloating, and gassiness. Triggers are people with irritable bowel syndrome have a sensitive intestinal tract in which stress and diet may play a role. Stress. For people with irritable bowel syndrome, stress can stimulate spasms in the colon, causing discomfort and pain. Diet. Some people with irritable bowel syndrome find symptoms worsen after eating large meals or high-fat foods. When symptoms become worse after drinking milk or eating dairy products, this may be due to lactose intolerance. The best way to manage IBS is to understand what may cause episodes of discomfort and then work to eliminate or minimize them. While medication, stress management, and probiotics can help, the focus is on diet and eating habits. Simple changes in diet can offer relief and reduce future flare-ups. Overall, for irritable bowel syndrome, it is important to establish regular eating habits. Eating at regular times helps regulate the bowels. Eat small, frequent meals instead of large ones. This will ease the amount of food moving through the intestinal tract. Eat fiber-rich foods. Try whole fruits, vegetables, beans, and whole grains, including rolled oats, brown rice, and whole wheat bread. Make changes slowly. Fiber helps move food through the intestine, but it takes time for the body to adjust to eating more. Adding too much too quickly may result in gas, bloating, and cramping. Drink enough fluids. Fiber draws water from your body to move foods through your intestine. Without enough water and fluids, constipation may occur. Watch what you drink. Alcohol and caffeine can stimulate intestines. This can cause diarrhea. Artificial sweeteners can contain sugar alcohols such as sorbitol, mannitol, and xylitol, may cause diarrhea too. Carbonated drinks can produce gas. Identify problem foods and eating habits. Keeping a food diary during flare-ups can help figure out what the patient may be eating that's causing a problem. The FODMAP diet has generated a buzz lately. FODMAP is spelled F-O-D-M-A-P. It's an eating plan that was originally developed to help manage the symptoms associated with irritable bowel syndrome. FODMAP is an acronym for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. They are short-chain carbohydrates found naturally in many of the foods we eat. These particular types of carbohydrates share three important characteristics. 1. They are poorly absorbed in the intestine. 2. Draw extra water into the intestine. 3. Are rapidly fermented by bacteria in the bowel. Depending on the quantity consumed and an individual's tolerance, FODMAPs can lead to increased gassiness, bloating, abdominal pain, and diarrhea. Next is a chart showing high FODMAP carbohydrates, along with examples of high FODMAP foods. The first carbohydrate on the chart is lactose, and foods that are high in lactose are milk, ice cream, yogurt, and soft cheeses. The next is fructose. Foods that are high in fructose are apples, honey, mangoes, pears, and watermelons. The next are fructans, which are included in foods such as artichokes, asparagus, beer, garlic, onions, and wheat. Polyols are in apricots, cherries, peaches, prunes, sorbitol, and xylitol. Galactans are in beans, Brussels sprouts, cabbage, lentils, and soy products. Here is how a low FODMAP diet may work. This diet starts with a low FODMAP period, usually ranging from 6 to 8 weeks. Then a patient will gradually reintroduce certain FODMAP-containing foods. During the reintroduction period, it is vital to keep track of signs and symptoms of gastrointestinal distress in order to help identify food offenders. Reintroduction is important because over-restriction can cause harm as well. So, cutting too many fruits, vegetables, plant-based proteins, and dairy foods from the diet can lead to increased risk of deficiencies in nutrients such as fiber, minerals such as calcium, protein for vegetarians or vegans, and vitamins A, C, and D. Remember, this is a low FODMAP diet, not a no FODMAP diet. It is highly individualized therapy that was designed to help manage symptoms, not to cure them completely. Here is some information about over-the-counter medications and supplements and how they relate to irritable bowel syndrome. The antidiarrheal loperamide or Imodium has been found to reduce stool frequency in patients with diarrhea, but it doesn't reduce pain, bloating, or other IBS symptoms. Laxatives such as polyethylene glycol or Miralax sometimes are used to treat IBS, but aren't recommended by the American College of Gastroenterology, as there are other treatments that may provide the same relief from constipation, but with fewer potential side effects, such as nausea, abdominal cramping, and gas. And finally, fiber supplements may be recommended to relieve constipation when increasing dietary fiber is ineffective. Although wheat and corn bran haven't been shown to be effective in treating IBS, positive results have been seen when adding psyllium, a soluble fiber supplement, to the diet. Although more research is needed, some studies suggest that probiotic supplements, especially those predominantly containing Bifidobacterium infantis, helps alleviate abdominal pain, bloating, and irregular bowel movements. Probiotics are microorganisms that supplement the GI tract's natural bacteria, helping to balance intestinal flora. In conclusion, for patients with minimal symptoms and/or a lower level of motivation to make major dietary changes, consider implementing some of the traditional dietary strategies for treating IBS, including eliminating or minimizing high gas, high fat, lactose-rich and/or fried foods, alcohol and caffeine, consuming smaller, more frequent meals instead of larger meals, adding foods high in soluble fiber, and ensuring adequate amounts of liquids are consumed. For patients with moderate to severe symptoms and those who are motivated to make major changes to their diets, consider implementing a minimum 2 to 3 week low FODMAP diet. In addition, food sensitivity testing with a patient-specific elimination diet may be considered for patients with IBS/disease and motivated clients with moderate to severe symptoms who haven't found relief from a low FODMAP diet. Next, we'll move on to irritable bowel disease. Irritable bowel disease includes ulcerative colitis and Crohn's disease. Combined pharmacological and nutritional therapy may induce remission of the disease. Patients have high malnutrition, and this is linked to poor outcomes. Sometimes IBD patients require tube feeding, which is feeding through a tube into the stomach, or total parenteral feeding, also called TPN, total parenteral nutrition, during active states of their disease. It's important to assess and identify malnutrition in patients with irritable bowel disease. The goal is to improve the overall state of nutrition. Consequences of malnutrition in irritable bowel disease can include growth failure, weight loss or protein energy malnutrition, and reduced muscle mass, bone deficiencies, and micronutrient deficiencies. Micronutrient deficiencies are common in patients with irritable bowel disease. The frequency depends on the type of disease. Most are more common in Crohn's disease than in ulcerative colitis, disease location, and disease activity. Routine laboratory studies indicated for nutritional assessment in patients with IBD include hemoglobin, albumin, and vitamin D, vitamin B12 in patients with Crohn's disease affecting the terminal ileum, measurement of serum concentrations of folate, vitamins A and E, parathyroid hormone, prothrombin, magnesium, calcium, phosphorus, and zinc may also be indicated based upon disease severity and location. The diet can certainly affect symptoms of irritable bowel disease and may play some role in the underlying inflammatory process, but there is no evidence that anything in one's diet caused or contributed to irritable bowel disease. Once someone develops irritable bowel disease, however, paying attention to what is eaten may go a long way towards reducing symptoms and promote healing. A healthy diet can maintain good nutritional status and manage symptoms. Medications are recommended to effectively treat IBD. The importance of good nutrition. In IBD patients, especially people with Crohn's disease whose small intestine is affected, are prone to becoming malnourished for several reasons. Loss of appetite as a result of nausea, abdominal pain, fear of eating, or altered taste sensation may cause inadequate food intake. Chronic disease also tends to increase the caloric or energy needs of the body. This is especially true during disease flares. IBD, particularly Crohn's disease, is often associated with poor digestion and malabsorption of dietary protein, fat, and carbohydrates, water, and a wide variety of vitamins and minerals. Thus, much of what a person eats may never truly get into the body. Good nutrition is one of the ways the body restores itself to good health. Therefore, every effort must be made to avoid becoming malnourished. Restoring and maintaining good nutrition is a key principle in the management of IBD for several reasons, including the following. Medications tend to work more effectively in people with good nutritional status. When proteins and other nutrients are lost in IBD, more food must be taken in to compensate for these losses. That may be difficult for many patients when intestinal symptoms are active. Lost proteins, calories, and other nutrients may cause growth issues in children and teenagers. Weight loss in women and girls can have an impact on hormonal levels, resulting in menstrual changes or missed periods. Foods to choose and foods to avoid. In general, most people with IBD should eat a well-balanced diet with a lot of variety. It's recommended to create a customized diet based on which disease, Crohn's or ulcerative colitis. For example, Crohn's patients, whether there is an intestinal stricture, narrowed areas of the bowel, or if the patient has ever had a blockage before. Also, note which part of the intestine is affected, and finally, if the disease is active, if they're having symptoms, or inactive, if they're in remission or not having symptoms. Irritable bowel disease for active disease. Avoid trigger foods, foods that have caused problems before. Certain high-fiber foods. Avoid nuts, seeds, popcorn, high-fat foods, caffeine, alcohol, spicy foods, raw fruits and vegetables, especially ones with skin, prunes, beans, dairy products as tolerated, and large food portions. Choose fruit juices, applesauce and bananas, bland, soft foods, plain cereals, white rice, and refined pastas. Fully cooked vegetables and potatoes without skin. Small, more frequent meals. Nutritional supplements, if loss of appetite. Vitamin and mineral supplements. Protein is tolerated, such as lean meats, fish, and soy. For inactive disease, if the patient is experiencing symptoms of IBD, focus on maintaining good nutritional status. Elements of a well-balanced nutrition diet include 8 to 10 glasses of water a day to prevent dehydration, carbohydrates with more soluble fiber like oat bran, legumes, and barley, protein like meats, fish, eggs, nuts, and poultry and soy, healthy fats like omega-3 fatty acids, olive oil, and canola oil, deeply colored skinless and seedless fruits and cooked vegetables, vitamin and mineral supplements, and finally, dairy/calcium, a dairy substitute if the patient is lactose intolerant. Special diets. Many people with inflammatory bowel diseases have reported benefiting from a particular diet. However, most diets have not been scientifically proven to prevent IBD or provide sustainable disease control. There's a lot of debate in the medical community regarding the benefits of these diets. Special diets continued. Some diets may increase the risk of malnourishment because they involve avoiding certain food groups that provide valuable nutrients. A diet should not replace medical treatment. There is no single diet or eating plan that will do the trick for everyone with IBD. And notice that this is different from irritable bowel syndrome, as discussed before. And finally, we'll talk about the 7 talked about diets for irritable bowel disease. First is the elimination diet. It involves eliminating certain foods from the diet to see which ones may be causing problems. A food journal is helpful with this diet. Second is the low fiber with low residue diet. This minimizes the intake of foods that add bulk residue to stool, raw fruits, vegetables, seeds, and nuts. It is sometimes used during flares or in patients with strictures, narrowed areas of the bowel. It is also used for patients with diverticulitis, which is an infection in the colon. Third, the colitis 5-step formula uses a natural pathogen killer to eliminate infection and, when used with proper diet and physical activity, may put digestive system back in order. The specific carbohydrate diet is next. This involves reducing poorly digestible carbohydrates to lessen symptoms of gas, cramps, and diarrhea. It consists mainly of meats, vegetables, oils, and honey. Next, we have the Maker's Diet. This focuses on 4 components of total health: physical, mental, spiritual, and emotional. Number 6 is the Total Bowel Rest Diet. This is a short period of complete bowel rest, during which time patients are nourished with fluids delivered intravenously. This may decrease IBD symptoms. And finally, number 7 is the Elemental Diet. This diet limits carbohydrate intake to reduce microbes that might contribute to IBD symptoms. This brings us to the end of the GI nutrition review. References are given at the bottom of slides throughout the PowerPoint. Thank you.